should be started.
There you go. Perfect. Thank you. Well, welcome everyone. I'm going to call to order this meeting of the Assembly Health Policy Committee meeting. It is February 2nd at 10:04 a.m. And Travis, if you could call roll, please, that'd be great.
Sure thing. Ms. Allard?
Here.
Mr. Constant? Mr. Dunbar?
Here.
Ms. Kennedy? Ms. LaFrance?
Here.
Mr. Perez-Verdia?
Here.
Mr. Peterson? Ms. Quinn-Davidson? Mr. Rivera?
Present.
Mr. Weddleton?
Here.
And Ms. Zoltel?
Here.
Great. Thanks, Travis. Well, welcome everyone. Appreciate you being here today. We are going to begin the meeting. There is a number of documents. If you haven't had a chance to review them, they are on the Health Policy Committee website. So please feel free to go there and to review those. I am going to start just as a reminder. If you want to ask a question and get in the queue, just put yourself in the chat, and I'll be trying to sort of watch that. And for the presenters, if you could, occasionally pause, so that if someone has a question, we'll be able to jump in. But with that, I am going to hand it over. Who is going to begin with the presentation on Crisis Now? Who's up first? Mr. Boyer.
Yep.
All right, great. Go for it.
All right. Thank you. Appreciate the introduction, Chair Perez-Verdia and fellow Assembly members and all the members of this municipality of Anchorage and general public who are attending. This is a great opportunity. We really appreciate the opportunity to talk with you today. And I believe we have a few PowerPoint slides, if they could be pulled up.
Yep.
Yes, I gave Mr. Boyer presenter ability, so he can share them, or I can share them if he has.
Could you go ahead and share them? That'd be great.
Yes. Would you remind me the title of them?
Yes, it's Implementing a Behavioral Health Crisis System of Care.
Is it the Crisis Now?
Yes.
Okay.
Yeah.
Perfect. All right. I'll while he's pulling that up, I'll do a quick intro into what we're going to do. But first, I'm Eric Boyer. I'm a program officer at the Alaska Mental Health Trust Authority. And with me today, we have Michelle Baker, who is the Senior Operations Director for South Central Foundation. And we also have Renee Rafferty, who is the Regional Director of Behavioral Health Providence Health and Services. The three of us are going to go over a few slides to kind of get everybody an understanding of some of the work we're doing here in the Anchorage area and actually across the state, but specifically Anchorage. And I'll kind of give the high level overview in about 5 minutes. And then I'm going to pass it over to Renee, who will talk specifically about Providence and the work they're doing to stand up one component of the model. And then Michelle Baker will do the same. So again, thank you for having us today. The information that is contained within this presentation is all, if you go to the Alaska Mental Health Trust Authority website, you can access that information. And we have a detailed page on behavioral health crisis that can go into that. And of course, you can contact myself, Eric Boyer at the Trust. Katie Baldwin Johnson and Steve Williams are both on the call as well. They are also a couple of senior staff here that can answer questions. So as you see from the first slide, you might have heard the term crisis now bantered around over the last several months or years. And just to give you some context, Crisis Now is a framework for helping individuals who are having some level of behavioral health crisis out in the community, being able to meet them where they're at and stabilize them. That terminology came about in 2016 through a white paper that a number of thought experts put together. Since then, that framework, which you see in that slide, thanks for advancing that. We'll sit on this slide for a minute. You see those levels of the crisis framework: call center, mobile crisis teams, and then that blue box. And that's specifically what Michelle and Renee are going to address today. But that framework was really, instrumental, the Crisis Now white paper, in supporting the federal government's Substance Abuse and Mental Health Services Administration's toolkit, which came out in 2018 for how to do this. And it contained all the elements that were really best practices in that white paper and have come forward. And they really set the stage for us. And if you think about call center, we have 911 dispatch here in Anchorage. We have some crisis line support through Providence and some local entities. But then statewide, we have a crisis call center called Caroline, which is based in Fairbanks. Part of the work we're doing is working with all those groups to be able to work cohesively together so that we can respond to folks, because many people who have a behavioral health crisis can get their needs met over the phone. But sometimes a few people need that extra level of care, which is where a mobile crisis team comes in. And we know through the work of Mike Riley and Jennifer Pierce at the Anchorage Fire Department, they've been really instrumental in being able to meet some of that need and stand up some of those services of being able to go out into the community. And we really, at the Trust and our partners, we really support that. And you might ask who our partners are. Our partners are the Assembly, the municipality of Anchorage, and that includes fire and EMS and APD, but also thinking about the health department and our partners like Michelle with South Central Foundation, Renee with Providence, Alaska Behavioral Health, Aquila, all those organizations that provide services, and then some of the support organizations like NAMI Anchorage. If you could go to the next slide. What you see, those elements contained in that blue box, when you think about meeting people where they're at in the community who are having some level of struggle, behavioral health, and that's mental health issues coupled with substance use issues. Some kind of drug might be on board, alcohol, of course. And when people are in that stage, they need somebody to talk to and they need somebody to respond. That's that call center, that's mobile crisis, that's APD, it's co-response. It's all those things, the core team. Those are all elements where somebody could respond. But some of those folks need an extra level of care, and that's where they need somewhere to go. They need somewhere to go that alleviates the pressure on the emergency rooms at our hospitals, and it alleviates the pressure that Anchorage Police Department might feel needing to take somebody to the Department of Corrections or to jail. With that in mind, a lot of those folks can get the level of care they need, and you can see that with these two elements. 23-hour stabilization is a short-term outpatient ability. If you think about 23 hours and 59 minutes for folks to be able to meet that need in a real level of high engagement and rehab. And you see that they're not in beds, they're in a recliner. There's flexible integrated staff. So you have behavioral health staff, you have peer support specialists, and you have medical staff, nurses, psychiatry, and you get folks in the door so that they can be assessed, screened, and stabilized. Some of those folks might not be stabilized in that arena and need a little bit more support. And that's where short-term and inpatient, it's actually short-term residential, and you'll see that reflected with Michelle and Renee's slides. And that residential is a 2 to 7 day stay. So you can kind of see where a mobile crisis team might spend an hour with somebody in the community. If they need another level of care, they could go to the 23-hour. And if they need more than that, they could be up to a week in a short-term residential. And that's where there's actual beds, but you have a similar flexible engagement and rehabilitation support for folks coming into that level of care. Both of them have integrated staffing patterns, and it really lengthens and stretches our crisis continuum of care. I'll pause there just in case, Chair Perez-Verdia, if there's any questions that need to be answered now before I pass it over to Renee.
It does not look like there's any questions at this time, so go ahead.
Okay, yeah, if you want to queue up the next slide, and Renee, I will pass it over to you.
Thank you very much. I'm really grateful to be here today and to be part of this collaboration. Providence has been working on how do we care for our community in the crisis. We have a history of collaborating with other entities to build the psychiatric emergency room. And in the last year, we also have expanded our services for crisis to have a walk-in clinic in our substance use, and we handle ambulatory withdrawal and medication-assisted treatment in that walk-in clinic. And we also expanded to provide services in the shelter at the Sullivan during the last year. And so we were very excited when we were approached to look at this, because we know that the need is great within our community to have the right type of care and to have no wrong door when you're in a behavioral health crisis. We'll go to the next slide. So Providence has been planning over the last 9 months to look at, and actually in reality, we've been working over the last few years partnering with the municipality and South Central Foundation and Trust to just how do we transform our system? What are the things that we can do next to really expand our services? And I think Eric did a great job of talking about the services within a stabilization center. And Providence is working right now to plan to open a 23-hour crisis stabilization center and a 24-hour residential. You can see there that we're planning at this time to have 12 chairs in our 23-hour and 10 to 12 beds in our residential. We know that there's a need for intensive case management for serious and persistent mental illness and for substance use. We want to expand what we're doing currently and ensure that not only are people having access to care when they're in crisis through that program, we want to make sure that they have outpatient care to prevent them from going into a crisis. Community behavioral health is critical if we want to see Anchorage continue to care for crisis at the lowest level of care. Those services can be expanded through the 1115 waiver. The population that we're addressing right now is adults experiencing a behavioral health crisis, and we would like to have both involuntary and voluntary care so that we can really serve patients that are struggling and need to be evaluated to see if they need to go to a higher level of care. Right now, they're going to either jail or they're in emergency room settings that don't have the specialized behavioral health care. And you can see that we really want to address those patients that are ending up causing challenges within the system, and then they're also not getting the care that they need. The clinical model is a trauma-informed, no wrong door approach, which means that we are going to provide the care, understanding that these particular patients that are in crisis are going to need different level of care that requires us to notice the triggers, the challenges that they face in the system, and then help them to immediately engage and to de-escalate. And that's what this model will be able to provide. It'll include discharge planning and partnership with other external organizations. In addition to data management, one of the things that I think is really important that Anchorage needs is to be able to, when we build this new system of care, it's going to be monitoring the data so we can continue to focus our efforts in the areas of process improvement together with fire, with police, with EMS and providers. What we see in San Antonio and we see in San Antonio, Texas, and in Arizona is that the communities that have really partnered to build this type of system change together have the spend where they want it, where they need it at the lowest level of care, and they also solve problems really fast because they've got the information they need. And I'm really, really excited to participate in that. And when we look at the staffing model, this staffing model, we've been learning quite a bit from our partners at RI and Crisis Now, and they've done this for a long time and have seen that the staffing pattern really actually addresses the needs where you have a behavioral health nurse, you have nurse practitioners, the oversight of a psychiatrist, but you really rely heavily on peer support and behavioral health clinicians that are trained to provide that clinical intervention immediately alongside of the care with the providers.
And
The
Renee,
location, yeah.
it looks like I want to, before you move on, I want to give Ms. Zolotel an opportunity to ask a question. Ms.
Absolutely.
Zolotel?
Thank you.
Thank you, Mr. Chair. Thank you, Ms. Rafferty. So my question is, I'm having a hard time reconciling the idea of involuntary for such a short period of time at a short-term crisis residential center, given our current statutory framework. So, and maybe you need to refer me to someone else, and that would be totally fine. But is there some conversation about changing the statutory framework for involuntary treatment? Because right now, depending on when that timing works, if you hit a weekend, you're well over that 72-hour calculation is actually multiple days. So just trying to see how that fits in the overall continuum.
Yeah, great question, Megan. I'll let Eric and the trust talk more about the legislative initiatives, but we're partnering to be able to address that.
Perfect.
Yep.
Whenever the time is right, that's fine.
Okay.
Thank you.
Yeah, we can help you.
Okay, great. Thank you. So we right now are looking at space we're exploring. We looked at a building that we had in our footprint that actually wasn't going to be clinically appropriate, nor did it fit the requirements for police or fire. We're looking at our regional building at this time and exploring the possibility of having the location there where we have both 23 and 24-hour. And we'd also be able to explore potentially having a behavioral health urgent care in that location too, which would be more like an outpatient clinic. So we're excited about that opportunity and still working on that. The status right now is that we've been planning, like I said, for 9 months, and we're continuing to establish the clinical model and the floor plan. And if all goes well and we're able to reduce some of the barriers related to developing this type of new program within our system, will be estimated to launch Q1 of 2023. And obviously that's going to need to move around as we address the barriers. The goals are really to expand access and meet the current need, and really in help the state and help the municipality address some of the challenges where we are forcing people with mental health needs into inappropriate settings like corrections, and also in settings where they don't have specialized behavioral health support. So we'd like to reduce the burden on API and provide evidence-based care for patients. So I'll just pause there, see if there's any questions.
Thanks, Renee. It doesn't look like there's any questions at this time.
And then the next slide, I think, Michelle, you are up.
Thank you, Mr. Chairman and Assembly members, for allowing us to share this information with you this morning. My name is Michelle Baker. I am the Acting Vice President for South Central Foundation's Behavioral Services Division. South Central Foundation is a tribal health provider in the Anchorage-Matsu Valley, and we also operate health clinics in about 16 rural communities throughout the state of Alaska. We're happy to partner with Providence and the Trust and the municipality on this initiative. About 3 years ago, as an operator of healthcare services and a co-manager of the Alaska Native Medical Center, when API was in a crisis, customer owners were in hospital settings for weeks and months at a time, receiving behavioral health care by untrained nurses and providers, and we were in a crisis situation. In many of our rural communities where we operate services, customer owners are placed in jail while waiting for higher levels of care because that's the only safe place for them. And the Behavioral Health 1115 waiver, one of the exciting things about the waiver is that providers can think about delivering behavioral health care in a different way, and to be reimbursed for those services that are provided. It's not perfect, but it allows us to think differently about our continuum of care. So we've been on this journey with the Trust and Providence for the last 3 years, looking at models, kind of understanding crisis stabilization, crisis residential, thinking about what our community needs based on conversations with the police department, the fire department, the mobile crisis team, and hearing feedback from providers in the community. About a year ago, South Central Foundation and the Alaska Native Tribal Health Consortium agreed to partner to build out 23-hour crisis stabilization for adults in the Alaska Native Medical Center, so on the east end of the hospital to start. And so we are currently awaiting for Indian Health Service approval because this is a federal facility. We do need Indian Health Service to approve our plans for the renovation of that space. We are also partnering with ANTHC to build a building near the current patient housing unit on the Alaska Native Medical Center campus for adult crisis residential, 23-hour crisis stabilization for youth, and crisis residential for youth. And that's probably a 3 to 5 year timeline to get those services up and running. We are currently looking at capital cost, capital funding opportunities to help us fund the building so that we can build that facility on campus to serve not only the Anchorage and the Mat-Su Valley, but also the larger tribal health system where they don't have the capacity to build out specifically the adult crisis residential and the youth residential in their regions. The Mental Health Trust Authority provided SCF and ANTHC a grant to look at renovating our space on the east end of the hospital. We're about a year into that. We've run into a little bit of delay in our planning on the east end due to the hospital trying to expand the footprint of the facility in order to allow the 23-hour program to be a little bit bigger, as well as our current fast track and emergency department in the hospital. The Mental Health Trust, Providence, and South Central Foundation, we've been doing a deeper dive and looking at, since this is a new program that we have not operated before, we've been spending a lot of time looking at various models that Renee and Eric mentioned in Washington, in Texas, in Arizona, trying to understand those clinical models and figure out what is the best clinical model for Anchorage and the customer owners that we serve here. Based on the no wrong door approach, making sure that, you know, it's culturally informed and meets our community needs. And I think Eric mentioned this, you know, early, the last piece of this, it's all of us working together. You know, Providence and South Central Foundation are looking at 23-hour and crisis stabilization, but it takes the entire continuum working together, the 988, the mobile crisis teams, the 23-hour crisis stabilization, and higher and lower levels of care to make sure that this continuum of care and this framework really works for the community and customer owners and everyone involved. And I will end there, Eric, and see if anyone else has any questions.
Yep. Thanks, Michelle and Renee, and we'll pass it back to you, Chair Perez-Verdia. And
great. That was really helpful. Just want to make sure that there's no questions in the queue at this point. Just anything else you want to share, Eric, or if anybody else from the trust wants to add anything. Actually, I do have a question now that I say that. Looks like Mr. Rivera has a question.
Yeah, thank you, Mr. Chair. I actually have just a few questions. So, and these are very basic questions. So I apologize. So first is on the Crisis Stabilization Center for Providence. I didn't see an opening date. Is that facility already open, or is there a plan to open that at some future time?
Thank you so much for the question. We are planning for 2023 and we're hoping for Q1, but we recognize that we have a lot of work to do to get the program developed and some of the barriers out of the way. But like Michelle said, so while we've been supported by the Mental Health Trust in planning grants, and then this collaboration, the opportunity to speak with you and work on challenges with state government as well, my hope would be that 2023 we will be open.
Okay, great. And then, if I may, Mr. Chair, just have a couple other ones. All right. So on slide 2, I think that does a really good job of doing encapsulating the different elements of Crisis Now. And I know this presentation was focused on the one in the blue box, but I actually had a question regarding the Crisis Call Center. Could you just sort of give me a little bit more information on the status of that? I know someone mentioned 988. Is that up and running? And if you could just talk a little bit about that.
Yeah, thanks for that question, and that's really important. So 988, as many of you might know, is federally mandated, signed into law last year, that by July 16th of 2022, all telecom companies across the U.S., including Alaska, will have the switches in place that if somebody dials 988, they will get the National Suicide Prevention Lifeline certified call center in Alaska, which is Careline, based in Fairbanks. And that the idea is kind of having the equivalent of the 911 system, but 988 being able to talk to a call counselor who can actually screen, assess, and triage what somebody's needs are and try to help stabilize them in community, many times with third parties. So it's really taking all those behavioral health calls, which is really, the idea is to take the burden off our dispatch centers with 911 and subsequently our law enforcement so that they can do the things that they're specifically trained for, and we can have a behavioral health response to somebody with a behavioral health crisis. So by July, GCI and all the other telecoms in Alaska will have that operating fully. The state of Alaska actually submitted a 988 implementation plan to the federal government, I think last week. And that is something, if you all are interested, I can share with the chairs and pass that around. And it's basically all our partners coming together to look at all the systems impacted. How are we going to help support this to make it effective and to work? Does that help?
That does. Fantastic. And I guess my last question, all of this work sounds amazing. I'm just curious regarding staffing. It's one of the things that we hear on a regular basis is that there isn't enough staff to do all of the work. So I'm wondering if you could just talk a little bit about that, what we're doing to address those issues.
Yeah, thanks for that question. And it's definitely something that Michelle, Renee, Katie, and Steve and I talk about a lot. We have to be smarter with the staff we have and come up with some creative solutions to bring in more staff, even though that seems daunting. What we've done, we had some foresight working with the state of Alaska, the Division of Behavioral Health, to last year to equip peer support specialist certification through the Alaska Commission for Behavioral Health Certification. So this equips and enables a whole nother segment of our society to be able to come and get jobs, to be able to get a good pay, and to be able to do work that can be reimbursed through Medicaid. Peers, as you might know, are somebody with lived experience, but specialized training to be able to meet the needs of behavioral health crisis. And so that's just one element, and we have a lot more that we're working on, but that's a great question, and be glad to do follow-up later if you're interested.
Great, thank you. Thank you, Mr. Chair.
Sure, I've got a couple more people in the queue. Next, Mr. Weddleton.
Well, thanks. I guess one thing that always jumps out to me, so 23-hour, my focal point is 24 hours and then you switch. So maybe just tell me, I'll probably ask that every time I see it. But then, a bigger question, it's, these sounds like good plans, but it's so far in the future when the need, of course, is like at this moment. And we've got, I don't know if they quite feed into this mobile intervention team. And then we've got our mental health first responders that are set up now. And if they can't handle something on site and calm things down, where do those people go now?
Yeah, Renee or Michelle, do you guys want to take that?
This is Michelle. I could, for customer owners that currently experiencing a behavioral health crisis, they can go to the Alaska Native Medical Center emergency room. We currently have a behavior urgent response team that is made up of psychiatrists, crisis clinicians that are able to consult with the ED docs and the physicians in the Alaska Native Medical Center to do assessments, help stabilize, provide care, and if they need higher levels of care, they can start the paperwork in order to do that. We've had that program for many years, and our goal is once we transition to 23-hour crisis stabilization in the hospital, that the majority of those staff would move to the 23-hour program, and we will still have staff available to provide services in the A&MC emergency department.
And I would just add that we have a similar scenario. We have the PsychED that provides crisis care for a high level of acuity in our community. So patients can come in through police or fire and receive care. And then we, like I talked about before, we have our walk-in clinic. And so we've been able to expand ambulatory detox to people that are struggling with substance use and are in crisis around that could escalate and move them to the ER, so they're prevented from going to the ER. And I agree with you that the need is very high right now, and we are moving very fast in this process. Actually, this type of planning usually takes longer if we didn't have the support of the trust as well as the collaboration that we built years ago. We wouldn't be where we are. And Providence works very closely with the mobile crisis team and has provided clinical supervision. We also share the Restore Hope grant. So we were trying to make sure that we were, partnering to increase the access to behavioral health care within the mobile team early on.
Yeah, and this is Eric Boyer at the Trust. I would just add in too that these services, when they come online, will help us avoid some of those pitfalls that were described, and it will equip South Central Foundation and Providence to really expand the continuum of care, meet people where they're at, and really serve that need, so that law enforcement and corrections and emergency room use can be diminished.
Thanks. So it sounds like you have the staff somewhat, and that they would move to a different physical location that would be better equipped to handle the problem. Is that kind of a quick summary?
This is Renee. No, that's a real challenge, and we wouldn't necessarily move any staff. We'd hope to continue to work on workforce challenges. That's going to be like something like Eric mentioned. We're going to need to continue to address that issue, but we would keep the psychiatric emergency room. I believe that it will continue to change, but we believe the need is great, and we would have to hire new staff for the 23 and the 24-hour.
All right, thanks.
For South Central Foundation, we have some staff. We don't have all the staff, but to build out all of these programs, workforce is a challenge, and we will continue to partner with the trust and others to make sure we have enough nurses in our system, clinicians, peer support staff. So all levels of providers are needed to build out this entire continuum of care.
Great. Thank you.
Thank you.
Mr. Weddleton. Okay, great. Next we have Ms. Zalatel.
Thank you, Mr. Chair. So I'm a huge proponent of Crisis Now, but what I would really like to see as we continue these conversations, if it's possible to I like this graphic we're sharing right now from the call center to the short-term residential beds, but to intersperse the existing assets and where they'll fall along the continuum, particularly at what point would a client be referred over to, you know, a DET or API? You know, where does that asset along the continuum come into play, and kind of looking at the timeline of someone moving through this system, because I think the amount of time someone spends from first interaction to stabilization, I mean, it's a very traumatic experience, even when we do best practices, and really just getting an understanding of the mechanics and how we leverage all the various resources so that as a municipality, we can make sure, as we consider where our, you know, mental health investments are being made, that we're making the biggest impact, whether that's through the mobile crisis team or other opportunities. In particular, this use of the term short-term residential beds, it feels a little bit like a misnomer to me because it is so short-term. It's really inpatient care. And so I'm curious why the term residential, other than just to indicate that it's inpatient, because it sounds and seems a lot like hospitalization.
Yeah, thanks for those questions. That's great. Renee, were you going to answer that?
Whatever, I'm happy to, unless you would like to.
Go right ahead.
I do, you know, that's a really important call out, and I think that we are going with terms that fit what we already have within our state system, and we have, you know, advocated for different nomage to make it clearer. And I think you're absolutely right that that is a challenge in terms of the names are different in different systems, but it does absolutely mean that shorter term acute care. It is not often residential is determined as a longer term care. So that's a good point.
Okay, that's helpful, because I also think if you're going to be looking at this with the youth system, you know, we have, you know, Anchorage-based residential care for youth, and just really, yeah, if there's ever the opportunity to take this graphic and lay it within the youth system and the adult system as the assets exist now, I think that would really provide a comprehensive framework to understand where we're headed with the expanded system. Very exciting, but just want to make sure get a full understanding. Thanks for being here today.
Yep, you're welcome. And I think in the near future, we'll have some mapping graphics that show kind of this flow and where we're going that'll, I think, help explain exactly what you're asking. So thanks for those questions.
It looks like that's all of the people in the queue. I just want to send a big thank you to everyone, all the presenters. That was really great information, and just a few other pieces. We, as a committee, I've shared this with folks at the trust, but just want to say it to the full committee. Are planning on continuing to have this as a primary topic for the rest of this year. And so if there are policies, if there are actions that the municipality, the assembly can take to support this work as it progresses, please keep us informed, and we'll continue to think about how we can support the growth and development of this work. Thank you all for the work that you're doing. It's so important and so vital for our community. We're gonna move on to our next topic. I did want to. There are a couple of documents in the that were posted on the website. A current COVID update. I think it's from January 25th, and there's also a number of questions that were sent and the answers to those. I know that Ms. Demboski is here. I don't believe there's anybody from the health department attending today, but Ms. Demboski, did you want to, in terms of an update, share any information with the committee?
Thank you, Mr. Chair, and you are correct. I am here representing the administration. Yes, I appreciate your questions. I think you sent us 20 questions. We responded to those questions in writing, and then we provided a 15-page supplementary document update to the Health Policy Committee from our medical officer as well as our epidemiologist and our healthcare director. So hopefully people have had time or will have time to read those reports. And if you have questions, we're happy to answer them. Just forward them to me and I'll get you an answer as quick as possible. With respect to testing, as you know, Mr. Chair, we have transitioned to private sector testing as much as possible, which in my written answers, we have pointed out that we've saved in just 55 days time, we've saved $5.4 million by shifting to a privatized model versus just a government sponsored model. Additionally, we are still obviously in the middle of a pandemic, but to our relief, we have not seen Omicron have as much as an impact as the Delta variant did on our municipal workforce. That's something that we are monitoring, as well as the stats that are coming from the state on the community transmission. So with that, I think the answers are substantive and they're complete. If you have any questions, I'm happy to relay those to the health department or the medical officer, whomever is appropriate, should those questions rise. Thank you.
Great. So I have a couple of questions, but just want to go to the chat. Are there members that have questions for Ms. Demboski at this point? Yes, Ms. LaFrance.
Thank you, Mr. Chair, and thank you, Ms. Demboski, for being here. I had a question on the testing and the note about privatization, saving money in that 55-day time period. And I was wondering if you had the number of tests that were successfully administered in that time period compared to other times and numbers for administration of tests. Thanks.
Sure, thank you. I don't have it in comparison to other time frames, but I do know that in that time frame, there were approximately 55,000 tests that were administered.
Great.
Thank you. Thank you, Mr. Chair.
Yep. So I wanted to pose a couple of questions. I think we recently heard that the health department has hired some new staff, which is great. And I was just wondering if you could give us a brief update on the staffing, so who they are and their roles, and in terms of the capacity for the health department, if that's going to make a significant change.
Sorry, I had myself on mute. Happy to. So. What I would like to do is I would like to get together a bio for each of the individuals that have taken over. One is for the administrative portion and the other is obviously for the healthcare portion. But I think it would be most beneficial for me to get you a couple little bios on each of them so you kind of know their background. I will tell you both of our individuals that have joined the leadership team for the health department are both incredibly experienced. This is not new to them. And they come to the municipality with a great depth of knowledge and professionalism. So we're very excited for them to join our team. I'll be happy to get you that follow-up information.
Great. And I think that the second thing is probably more of a statement, but there's likely a question in there. I received a call from a business owner today who said that one of his concerns right now is really just making sure that he and his staff and his customers are receiving good information and current information. And I guess my question is, now that some of the staffing has been filled in the health department, is it possible for us to have an epidemiologist attend this meeting and be able to not only provide the most current information, but field questions from the committee? Is that something that you think is going to be possible in the future?
Mr. Perez-Verdia, I think I have indicated to you on numerous occasions that staffing of assembly committee meetings is done basically on an evaluation basis of resources and mission need. And for that, again, the epidemiologist at this point has included a lot of her information in the 15-page attachment that I've given you. The municipal website is up to date. So we encourage members of the public as well as members of the assembly to go to that resource. We are also in the process of getting another, one RPIO from the health department moved out of state. And so we're in the process of replacing him. And our goal is to try to be as accessible as possible and get good information out there. And it remains to be the best place to go for the most current information, including the dashboards, is to go to the COVID response webpage on muni.org.
So I'm just trying to make sure I understand the answer that I got. What I'm trying to understand is that depending on the topic that's being discussed in the meeting, and is that the defining factor as to whether we would have someone like an epidemiologist from the city attend or not? I'm trying to understand. I realize that you're trying to make strategic decisions in terms of staffing and time and capacity, but I have heard overwhelmingly from members of the community as well as members of this committee that they feel like it would be a benefit to have someone representing the health department, specifically an epidemiologist, be at this meeting. And so that's what I'm trying to clarify. If that's not going to be possible in the future, or if there's a different process that we need to go through in order to make that happen.
As I've stated repeatedly, staff availability is on a case-by-case basis, depending on the mission needs and the availability of the staff, and frankly, the priority of what they need to accomplish. We provide that information routinely. We have provided that information. We continue to direct the public to the website. That's the best source of information. And as available and as the mission allows, you know, it's a cost benefit analysis that we bring people forward. And I have said repeatedly, any questions you have, we're happy to answer those questions. I'm here representing the municipality. I'm here representing the administration.
Okay. All right. And it looks like I have someone in the queue. But let me just finally say that you know, I appreciate the things that you're saying. I appreciate the answers that were given. A number of the answers that were given were simply proceeding as normal, and that doesn't give. So what I'm trying to figure out is, as chair of this committee, how I can get more detailed information about things that are going on with the health department that are of interest to the community and to this committee. And so I just would say I'll continue to work with you on that. If there are other ways that I can format questions or do that in a way that gives us more information that I think is needed. And so I'll just leave it at that and say I'm happy to do whatever I can to get the information that is being requested. So. And I'll move on to Ms. LaFrance. Looks like she has a question.
Thank you, Mr. Chair, and maybe more comments actually. As a former chair of this committee, as a former co-chair of this committee, you know, we were accustomed to collaboration with the administration and acted as partners in the municipality's mission of public health. And I just want to stress too, and along the lines of the comments you made, that I believe this is the best way to serve the residents of the community, for this committee to have access to members of the health department, especially the director. I appreciate the Muni manager's efforts to facilitate and serve as a conduit for providing that information. It's not a substitute for those direct conversations and that collaboration. And I think that, you know, one of the benefits of having these, you know, the real-time conversations and working together again on the mission of public health is that there's a deeper understanding of what some of the items that are brought forward to the assembly for assembly support. And I just want to stress the value of making that depth of knowledge available to the committee and available to assembly members, because there is such tremendous value on working collaboratively on public health issues. And I just want to say, Mr. Chair, I appreciate your efforts to have those open lines of communication and to respond to committee members' requests for having that kind of dialogue. So thank you, Mr. Chair.
Sure. Okay, and I want to make sure we have some time for public comment. So, but it looks like I have one more person in the queue, Ms. Allard.
Thank you, Mr. Chair. I appreciate it. I just wanted to say that us as a body, as an assembly body, have received all the answers to all our questions, and it would be fair to say the administration has been open in responding to every single question. So I do feel like we're working with the administration, and that's all I had to say. Thank you, Mr. Chair. I appreciate it.
Thank you. Thank you, Ms. Dombosky. You know, I will continue to work with you. I will just be frank. It has been strange to not receive any communication with the director of the health department, to reach out to him numerous times and not receive any response at all, only from you, and to receive to have no communication. So
Mr. Chair, I think that's actually a false statement.
Let me finish. So I've sent texts, I've sent emails, I've made phone calls, and I have not received anything back directly from him. And so that's what I'm trying to figure out, is that I'd like to work with both you and him to make sure that the information that is being requested from the public and the information that's being requested from this committee is shared out. So that's been my challenge, and I will share that I will continue to work with you in a way that makes sense. But it's been a challenging last 2 months to try to figure out how best to work with the administration and the health department as it relates to this committee.
Thank you, Mr. Chair. And I'll just say that I know Mr. Dre spoke with you this morning because he told me he took your phone call.
No.
So all I'll say is I'm happy to give you any information you're requesting. We've done our very best to do that. We'll continue to do that. And when staff is available and it's appropriate, we are absolutely happy to make them available as the schedules permit. So thank you.
I did not speak with Mr. Drace, and I did not receive a phone call from Mr. Drace. I have not spoken or have an opportunity to speak with him in at least two months. So, all right.
Mr. Chair, if you'd like to say hello to him, he is on the call this afternoon. So you can say hi to him right now.
All right, great. Well, I'll just say, Joe, I would really appreciate a phone call, and I'd really appreciate an opportunity to chat with you. So, all right, we're getting close to the end of our time, but we've got a few more people in the queue, and I have to admit I'm not remembering Miss Allard. I think you got back in the queue, and then Miss LaFrance, and then Mr. Rivera.
Yes, thank you, Chair. I
Chair.
just wanted to say I apologize. I responded to Mr. Gerace, and he's responded to me, and maybe I could forward those emails.
Sure, that'd be great. Miss LaFrance.
Thank you, Mr. Chair. And just very briefly, I think it's important, while other members may have private conversations with some members of the administration, I think it's very important to have these conversations in the committee. And I would like to request that at the next meeting that the epidemiologist is available to answer member questions. Thank you, Mr. Chair.
Thanks. Mr. Rivera.
Thank you, Mr. Chair. Yeah, I got in the queue because that particular interaction that I just saw between yourself and Ms. Dombosky is somewhat alarming to me. I will say, for my part, chairing the Housing and Homelessness Committee, it is always, I think, beneficial for the mission of our committees if we can speak directly in committee and outside of committee with the subject matter experts. So I appreciate the work you are trying to do in this committee, Mr. Chair, and being able to facilitate these discussions. So I hope that we can continue to evolve in our ability to work with the administration and get our mission accomplished. Thank you.
Thanks. Okay, we just have a couple of minutes left, so probably only time for one person. but want to make sure if there is someone from the public who would like to speak, now would be the time. If you could unmute yourself using *6, and you'll have a few minutes to speak. I'll pause now. Is there anyone from the public who'd like to speak? All right, I'm going to take that as a no. I want to thank everybody for being here, and thank you for your time, and really appreciated the presentation. Have a wonderful day. This meeting is now adjourned.
Thank you, Mr. Chair. Thanks, Cameron.
Yep, thanks.